Welcome back to Cardiac Pharmacology, Series 2 of 4. Once again, Felix Marquez from Orlando Medical Institute. Let's continue on, talk about cardiac drugs. What we're going to start off with is what we refer to as anti-dysrhythmic type drugs. All right, pretty much these drugs are very useful in treating and preventing of cardiac arrhythmias or dysrhythmias. Some are useful in the treatment of atrial arrhythmias, as some we'll talk about are useful in ventricular dysrhythmias. So let's start with lidocaine. Lidocaine's been around for a very, very long time. It's an anti-dysrhythmic drug. We give it to multiple patients. Some of us know it as a local anesthetic drug, such as if you got a cut, you need a sutures. That's what they will inject into there is lidocaine to numb that area so they could suture it up. We know it that way. A lot of us know it that way. It's also one of the most used drugs in anti-dysrhythmic in cardiac arrest patients in the use of treatment of ventricular dysrhythmias. So what does it do? It suppresses depolarization and automaticity in the ventricles. So when the heart becomes severe irritable from lack of oxygen or has electrolyte imbalance, that threshold, that when the heart reaches that threshold, it fires, and that's when you get that QRS. Sometimes that threshold drops. When the heart becomes irritable, that threshold drops. So the heart fires prematurely, fires before it's supposed to. So instead of firing up here, it fires down here. So you get that premature beat. So what that lidocaine does pretty much is just raise that threshold back up. As I raise that threshold back up, I should knock out the PVC. That's what it does. So it maintains that, okay? So has really little to no effect on atrial dysrhythmias. So doesn't really work on atrial tissue. The onset's pretty much within 3 minutes is working, so pretty quick drug. I love it because how quick it is. The half-life is anywhere from 1.5 to 2 hours. And keep in mind, when we talk about these half-lives, it gives us a range because a lot of factors play a role. How functionable is the liver to eliminate the drug, biotransformation, right? What's the body's temperature? Is the patient's temperature really cold? If the body's hypothermic, then it's going to stay in the system a lot longer, and it's going to take a lot longer before it starts to work. Versus the patient was hypothermic, then their temperature increases. They'll burn faster, work quicker, but have a shorter half-life. So just I want you to keep in mind diseases and processes and what's going on with the patient's body determines where we at with that half-life, okay? So just keep in mind, anywhere from 1.5 to 2 hours we're talking. So lidocaine is used in the treatment of ventricular tachycardias, all right, and whether it be pulseless or patient with a pulse in V Tach. Also used in ventricular fibrillation, which is known as VFib. There is some contraindications. We don't want to give this with heart blocks. Second degree Morbus type 2 and a third degree, those high degree blocks specifically. But I'm gonna caution you lidocaine in patients with heart blocks, period, okay? So pay attention to that. Whenever PVCs occur with bradycardia, just stay away from that lidocaine. We're not going to give that lidocaine for those PVCs, and the reason why is because the patient is bradycardia. We don't want to jack this patient up any more than he already is. Okay. Take precaution in patients with central nervous system depression when you give it over 300 milligrams an hour, or we would like to say 3 milligrams per kilo. Don't exceed that dose. When you exceed that dose, this becomes more of a genetic anesthetic. All right, or general anesthetic, I should say, not a local. So it can actually suppress the central nervous system at a higher dose. So we don't exceed 300 milligrams or 3 milligrams per kilogram. All right, so exceeding these doses could put the patient into a coma, and worst outcomes, death. All right, so pay attention to that. There are some side effects. Makes the patient, could make them drowsy. Seizures could occur when you have lidocaine toxicity, so be careful. Confusion, hypotensive, bradycardia, heart blocks, nausea, vomiting. So it could cause slowing down the heart rate, could induce a heart block. So that's why heart blocks, bradycardia, all that stuff is a contraindication with lidocaine. Should be cautioned when you're given any other antidysrhythmic. You should not get into the habit of mixing antidysrhythmics. So if you give one, stick to it. Don't go back and forth because they do interact. All right. So Prekenamine, Amiodarone, all those all different types, beta blockers, calcium channel blockers. Pay attention when you give those drugs. All right. What's the dose of this medication? Well, if my patient is hemodynamically stable, so what I'm referring to, so I'm in V Tach with a pulse and I'm stable. So that means I got a good blood pressure and I'm maintaining a good mental status. So my mentation is good, blood pressure is good, but I'm in V Tach and I have a pulse. That's what we refer to as a stable V Tach. We're going to go ahead and we're going to give a bolus dose, all right? So 1 milligram to 1.5 milligram per kilo. So choice would be yours unless your protocol is specific. If that doesn't eliminate the dysrhythmia, right, I will go ahead with a second bolus so you can repeat a half of what you gave initially. So if I gave 1.5 milligrams first, I would probably go with 0.75 milligrams per kilogram. If I went with 1 milligram initially, then my second dose would be 0.5 milligrams, okay? Once again, we don't want to exceed 3 milligrams per kilograms because that could be detrimental to the patient, cause a coma, put the patient in a coma or cause death. All right, once you suppress that dysrhythmia, because lidocaine doesn't have such a great half-life, we want to maintain a dose. We want to maintain that therapeutic threshold. Remember, we raised that threshold back to where it needs to be. We want to maintain that. How we maintain that? With a maintenance dose. You can give anywhere from 2 to 4 milligrams per minute. Now, the question I always get, Felix, if I convert the patient with the bolus of lidocaine, do I automatically start a maintenance drip? Or do I wait to see if they start throwing PVCs again, then start the maintenance drip? You can do either way. All right. Also, always follow your local protocol, which your medical director wants you to do. But either way is an acceptable way of treating, how I should say, hanging a maintenance drip, whether it be immediately or once you start seeing these PVCs start to surface. So either way, it's an acceptable means of practice. But once again, you're gonna have to follow with your local protocols. What it suggests you do, that's what you'll have to do. So prekenamine is another drug, another antidysrhythmic that you probably could carry. I don't see it too often pre-hospital, but it's given in hospital. It's a class 2B drug. So HAS classifications of drugs, right? Class 1 means, man, absolutely give it. The research shows that it's positive, no side effects, very, very little side effects. This is a drug that's very beneficial. As a class 2A drug, shows it's beneficial, it's a great drug, give it, but there's some side effects. Just precaution yourself with those side effects. Class 2B drug, it does work, it works good, but there's potential for severe side effects. As a class 3 drug is, don't give it, could be harmful to this drug. So I like to think of class 2B to be discussed with the expert. So, such as this patient right here, we're talking about cardiac. Who's the expert? The cardiologist. Not the ED physician, but the cardiologist. So if I feel like this patient might benefit from prekenamine, I will consult with the cardiologist to see if this is the best choice drug to give to this patient. So it's a 2B drug, all right? So that's why I say we don't really carry this pre-hospital because we don't have a cardiologist available on our cell phone, our disposal to call whenever we need to. So 2B drugs are really probably left for hospital-based, that controlled environment versus us. But it's something we need to know. So it's also another local anesthetic and is used to treat ventricular dysrhythmias and some atrial dysrhythmias. Patients who have AFib with WPW, we normally want to give them calcium channel blockers, but because they have WPW, it's now contraindicated to give that calcium channel blocker to the AFib patient. Prekenamine is the class 2B drug that we probably go to for this patient. So it suppresses ventricular ectopy, so it's going to suppress that ventricular dysrhythmia, all right, which is pretty good. It's going to reduce the automaticity of the various pacemakers, meaning firing periodically from different locations, causing those PVCs. It starts eliminating those, so not too bad. It definitely slows the intraventricular conduction to a much greater degree than lidocaine would. So that's why it becomes a little bit more dangerous than lidocaine itself. The onset is anywhere from 10 to 30 minutes, so it takes a little bit to work, but still quick. Half-life is approximately 3 hours. All right, indication, well, if I have a cardiac arrest patient, I try lidocaine, try amiodarone, or I don't have it, and the patient is in cardiac arrest due to ventricular tachycardia with a pulse that they had that first, maybe consider giving it. Or I have a patient who has atrial fib with a pre-existing disease such as WPW. I will go ahead and probably give procainamide. All right, contraindicated, those heart blocks, those high degree blocks, second degree type 2, that third degree, stay away from them. Once again, I caution you to with procainamide with any heart block. Avoid patients who known suppress prolonged QT syndrome, because procainamide could increase your QT segment, okay? So it can prolong that QT segment. So be careful, all right? I'm gonna tell you, anytime you prolong that QT segment, or that QT interval is actually what it's called, the longer it is, the more chance this patient go into a lethal dysrhythmia such as VFib or asystole. All right, so pay attention to that, cardiac arrest, I should say. Avoid patient with CHF. Hypertension is common, so pay attention to vital signs. Take that blood pressure frequently if you're giving procainamide. All right, and monitor vital signs quite quickly. Can make these patients drowsy, seizures can happen, confusion, hypertension. You see, all antidysrhythmics have the same type of side effects. All right, heart blocks, nausea, vomiting. All right, it interacts procainamide with other antihypertension medications, I should say. So other antihypertension medications, if they take it, keep in mind this could interact with that. Be careful, because you could develop some toxicities as well, just like lidocaine. So both with lidocaine and procainamide could increase that medication's dose to develop toxic levels. So once again, stay away from intermixing different antidysrhythmic drugs. All right, we use this for ventricular tachycardia or AFib. All right, procainamide should be administered anywhere from 20 to 50 mics per minute until the arrhythmia is suppressed. Once you suppress this arrhythmia, stop the infusion. You have to stop the infusion. If not, you can end up severely hypertension or worse, cardiac arrest. So we do have some endpoints. When do we stop procainamide? As I just mentioned, if we suppress the dysrhythmia, stop it immediately. Cut it down. Take it off. If patient becomes hypotension, stop it. If the QRS complex is widened by 50%, so what my initial QRS was, if it's widened from that by 50%, stop it. Or if I total maxed out on 17 milligrams per kilogram, we need to stop the administration. Once you suppress it, you could consider a maintenance dose. Once again, this is going to be based on your protocol, but you could do it a maintenance dose of 1 to 4 milligrams per minute. We put 1 gram into a 500 milligram bag of D5W, which gives a concentration, a dose I have 2 milligrams per ml. This is a picture of how you would mix it. And we move on. So what's another drug that falls under the categories of antidysrhythmic is adenosine. So adenosine is another antidysrhythmic drug. It's natural occurring in the body. It's kind of like, I like to refer to it as a chemical defibrillator. So what it does is stops the heart for a very, 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 very short period of time, approximately less than 6 seconds, and then hopefully picks up its normal conductivity. So we give this drug to slow down really fast heart rates, SVT, right? So super short half-life. We're talking 6 to 10 seconds, very short, and that's the time it hits the circulatory system. All right, but pretty relatively safe to give. We don't see major bad outcomes with adenosine. It's a natural occurring substance in the cells that produces this. We give this for SVT, or what we call AV nodal or interruption, AV reentry pathways into SVT. So for some reason, there's a pathway that fires back into the ventricles, speeding the rate up. So can effectively terminate supraventricular dysrhythmia. So just straight SVT, meaning sinus tachycardia, that's a rate above 150. This works great. AFib, that's a rate above 150. A-flutter, not so much. All right, this really works good with the sinus tachycardias that are above 150. They work pretty well. Most of the time it suppresses it. Most of the time adenosine will change that dysrhythmia, bring it back to a sinus tach, less than 150. As I mentioned, approximately 6 to 10 seconds, its half-life, and it's pretty effective in about 90% of these cases, as I mentioned. So it's the preferred drug. It's the preferred drug to give in a sinus tachycardia that's above 150 that we refer to as SVT. All right. It doesn't have the hypotensive properties that calcium channel blockers have, such as verapamil. The onset, 20-30 seconds, works pretty quick. Half-life, just approximately under 10 seconds, average 6 seconds. So we give this to patients who are refractory to vagal maneuvers. So I have a stable SVT patient. We tried vagal maneuvers, didn't do nothing. I'll consider giving adenosine at this point. All right. So these are given once again for supraventricular tachycardias, narrow complex tachycardias. All right. This doesn't work on ventricular tachycardias. So contraindicated in patients who have AFib. It's contraindicated because it's probably not going to work. But if you don't know it's AFib because the rate's so fast and you thought it was just a regular sinus tach, you can give it, but just watch the underlying rhythm because it's going to slow it down enough that you could recognize this was AFib. Second dose is not going to do nothing for AFib. So kind of contraindicated. As I mentioned, ventricular tachycardias, polymorphic, absolutely 100% contraindicated. Heart blocks, probably want to stay away from it. Sick sinus syndrome, definitely want to stay away from it. That SA node is sick. The last thing you want to do is start messing with it by giving adenosine, okay? Or if you know they have a known hypersensitivity, then I'll stay away as well. Typically, as I mentioned, very, very, very short half-life, so it's not lived long. Take precautions, could cause some PVCs or some PACs. We don't see that too often, but it could, so pay attention. Could cause sinus bradycardia. Can actually cause a degree of periods of time where the patient is asystole. So when you do give this drug, make sure the patient is in a position where they can't fall. So lay them down, 45-degree angle, semi-Fowler's position, not in the sitting position or standing position. Flush, they can develop flush skin. You'll see that. It's one of the side effects. Headaches could be, shortness of breath, dizziness, of course, even syncope, and nausea, because it does slow the heart rate down for a period of time. Could interact with other drugs. Amiodarone is like one of them, is a great example of one. So keep that in mind. Just pay attention to that. As far as dosages, 6 milligrams initial dose. It's a rapid bolus, as fast as you can do it, followed by a flush. What I like to do is I'll get my department, we carry 3 cc locks, right? So it takes 3 cc's of saline to fill that lock. So what I'll do is put the adenosine in the lock and then finish the rest with saline. So I have 3 completely filled that lock, put the saline on the other end. Then I hook that up to my main line. Then I just push the saline, and it pushes the adenosine that's in my line into my vein with the flush behind it. So I can get it to the heart quite quickly so I can get the full effect of the adenosine. If that doesn't work, the initial dose of 6 milligrams, we go ahead and go with 12 milligrams. 12 is a repeat dose. All right, so moving on. So we have cardizem, which is dalteizim, right? Pretty much known as cardizem. We call it cardizem. It's relatively one of the safer and more common calcium channel blockers give pre-hospital and in hospital as well. So is this calcium channel blocker? So what it does, it blocks the calciums at the channels, at the AV, slowing that AV conduction, slowing down that ventricular rate. That's what it does. So it's a calcium ion antagonist. So it's going to antagonize calcium. So calcium channels, which respond to AV, works off of calcium channels. Those calcium channels open up due to the influx of calcium. You start blocking the calcium, the channels start opening up slower. Starts opening up slower, slowing it down. It's going to slow the signal down, hitting the ventricles, slowing down your ventricular rate. So we give this to tachycardias to indirectly slow down the heart rate. Great drug to give. Keep in mind, they're on max dose because the last thing you want to do is block all the calcium and the channels don't open at all. And then they go to asystole. So pay attention to that. All right. Mechanism of action pretty much just causes vascular dilation and slows down conduction, as I mentioned, through the AV node. All right. Slowing down my heart rate, slowing down the rate indirectly. All right. So that's pretty much it. Also used in the treatment of angina because of its negative inotropic effects. All right. So it causes dilation of coronary arteries. You'll see that too often we give it more for the fast rate, such as AFib, A-flutter, as long as there's no WPW present. WPW is present. They have a history that is contraindicated, these calcium channel blockers. Onset's about 3 minutes. Half-life approximately 2 hours, so it works pretty well, okay? Indication, we give this to our stable patients, of course, great blood pressures. They have a good blood pressure. They still have great mentation. They're just symptomatic. And their heart rate's really fast. So we give it to a stable, narrow, complex tachycardia rhythm that means uncontrolled or unconverted by adenosine or vagal maneuvers. Now we're considered in SVT to go to now calcium channel blockers. All right, so we tried the vagal maneuvers, unsuccessful. And we tried the adenosine, unsuccessful. Now we go to calcium channel blockers such as cardizem. All right, so cardizem controls ventricular rate in patients with AFib or A-flutter. That's the first line drug for AFib, A-flutter. Once again, as long as there's no WPW present. Contraindication, severe hypertension or cardiogenic, and keep in mind calcium channel blockers can make you hypotensive. So if I'm already hypotensive, it's going to be contraindicated. Patients with ventricular tachycardia or Y complex, what I tell you, calcium channel blockers are given to tight complex. So cardizem is given to a tight complex tachycardic patients. And we got to be careful, patients WPW. If they have WPW, cardizem is contraindicated. All right? That's when we'll consider maybe precanamide. Precaution, it could make you hypotensive, so keep in mind when you give cardizem, pay attention to blood pressure and vital signs. Calcium chloride can be managed to take care of these calcium channel blocker overdoses. So if somebody had overdosed on a calcium channel blocker for some reason, calcium is the antidote. Should be kept refrigerated on very cool temperatures, and if it's outside that cool temperature, then it can be outside that environment approximately about a month or so. Then you have to change it up. So some side effects, nausea, vomiting, of course, dizziness, because it could make you hypertensive, headache as well, bradycardia, because it's slowing down heart rate, heart blocks, as well as hypotension. So pay attention to those things. As far as interactions, it can interact with beta blockers. Beta blockers also slowing down heart rate. So we don't want to mix a beta blocker with a calcium channel blocker. So we don't want to give metoprolol and cardizem to the same patient at the same time. We could really jack these patients up. So pay attention to that. Can make them bradycardic, and worst case, you give too much, can make them asystole. We don't want to do that. That's dead. DRT, dead right there. What's the dose? 15 to 20 milligrams IV bolus. A lot of agencies just go with a straight dose. Give 10 to 15 milligrams. But it could be anywhere from 15 to 20. But the actual dose is 0.25 milligrams per kilogram with a max dose of 20 milligrams initially. That should be given slow bolus over 2 minutes. If that didn't change it, we could give an additional bolus of 20 to 25 milligrams, or what we like to say, 0.35 milligrams per kilogram. In 15 minutes with a max dose of 25. So in 15 minutes, reassess, and we can go up to 25 milligrams max. Once again, slow bolus if you can, all right? You can do an infusion. There is a cardizem infusion of 5 to 15 milligrams per hour until you achieve that desired effect, okay? Another antidysrhythmic we refer to as amiodarone, okay? Pretty commonly given pre-hospital in cardiac arrest as well as in hospital, okay? Also known as codarone. As an antidysrhythmic, we refer to as amiodarone. So it's a very potent antidysrhythmic drug given to patients in cardiac arrest. It's the second line drug. First line drug is epi, second line drug in VFib or post V Tach will be amiodarone or lidocaine. Has demonstrated that it has a high indication of improving the ROS rates, return of spontaneous circulation. So, and that's those patients in cardiac arrest where we gave it, got a pulse back, patients did well. What's good about amiodarone, it could be not only given to ventricular dysrhythmias, it could be given to atrial dysrhythmias. So compared to lidocaine, lidocaine could only be given to ventricular dysrhythmias, has no effects on atrial dysrhythmias whatsoever, okay? So SVTs that are refractory to calcium channel blockers, refractory to adenosine, or maybe the patient has WPW, and you can't give cardizem and you don't have precanamide, maybe you can consider amiodarone, but you can take that with significant precaution, okay? Mechanism of action, prolong the action potential, kind of increasing that ventricular threshold as well. It affects the sodium, potassium, and calcium channels. It has some alpha, beta adrenaline blocking properties as well, so it could slow down heart rate, do all that good stuff, okay? Its onset is 2 to 3 days if you give it orally. If it's given IV, it's pretty quick. Works almost immediately within 2 minutes. Now, look at the half-life. The half-life of amiodarone could be anywhere from 40 to 55 days. So it's in their system a long time. See, that becomes a major problem with long-term care of these patients. Give me something for a short term, and now we have long-term effects. So that's why it's not really the favor for atrial dysrhythmias. They want you to try other type of drugs such as calcium channel blockers, beta blockers, stuff like that. Don't go right to this antidysrhythmic of amiodarone, okay? It's because it has a very long half-life. So this patient's going to be in a cardiac care for a long period of time because of its half-life. All right, so, but when you do about cardiac arrest, it's life-threatening. We don't care about half-life at this point. We will give the drug. So who we give it to? Well, VFib or pulses V Tach, or even patients who are stable with V Tach with a pulse. So let's talk about that stable patient that has V Tach. We could give it. Or a patient has AFib, you can give it. You thought it was a Y complex, it was a Y complex, maybe it had a heart block. That made the QRS complex Y. So a patient has AFib, has a left bundle branch block. The heart rate is 200. The QRS is Y because of the heart block. The left bundle branch block, I should say. It looks like V Tach, but we don't know because the rate's so fast we can't see the P waves. And you thought it was V Tach and it wasn't, and you gave Amiodarone, no foul, no harm, because this does work on atrial dysrhythmias, okay? So, but it's given mainly for ventricular dysrhythmia, such as VFib and pulses V Tach and V Tach with a pulse. We just give it differently. We'll talk about the dose in a minute. Contraindication, if she's breastfeeding, mom is breastfeeding, we probably don't want to give it because it could cross that barrier and the kid could end up absorbing this antidysrhythmic drug, all right? If you know the patient has some sick sinus syndrome, some sinus node problems, I'll probably stay away from it. High degree blocks such as a second degree type 2, third degree heart block, stay away. Sinus bradycardia, if they have a known hypersensitivity, definitely stay away as well. All right. One thing with amiodarone, it doesn't say it in here, but I want to go over it as well. Also with amiodarone, that's why it's not the favorite for atrial dysrhythmia as well. Anything life-threatening, of course, life-threatening takes the priority. Amiodarone increases your iodine levels significantly. Sometimes the levels could be so significant, it could create thyroid problems. It can actually destroy your thyroids. One thing your thyroids are very sensitive to is iodine. So exposing those thyroids to a significant dose of iodine can be detrimental to a patient, can throw them into endocrine emergency. So be careful with that. You normally don't see that too much with the IV bolus, but patients who are taking it orally long term. And when you normally see that spike in iodine is normally within the first couple of months of the onset of taking, first couple of months of taking amiodarone. After that, it tends to plateau. So those are things just I want you to be aware of when we deal with patients who are on amiodarone. So if you have a patient who is presenting with an endocrine emergency and it tends to gear towards, man, their thyroids are jacked up and you think it might be iodine, look at their medication. And if you see they're on amiodarone, PO, and next question I might ask them is, how long you been on this amiodarone? Oh, just got on it. Most likely that's the issue. So, but the issue is, if you take them off it, doesn't correct it. Why? Because amiodarane's half-life is 55 days. It's a long, long half-life. So damage will be done. So just precaution, okay? Some side effects can make them bradycardic, so put them on a cardiac monitor. Could increase ventricular beats, so pay attention to that. Prolong that PR interval, your QRS complex, and your QT interval. So bottom line is, when you give this drug, they should be on a cardiac monitor, and you should be paying close attention to what they're showing on that monitor. All right, could cause hypotension as well. All right, interacts with all the antidysrhythmic drugs. So if they're on other antidysrhythmic drugs, pay attention. Like I said, good practices, don't get in the habit of mixing these antiarrhythmic drugs. So we have VFib or pulses V Tach. The initial dose is 300 milligrams IV bolus. These patients in cardiac arrest, bolus it. If that doesn't work, can you give a second dose? Absolutely. You give a second dose of 150 milligrams. But if my patient has a narrow complex tachycardia, so they have V Tach with a pulse, we'll give 150 milligrams over 10 minutes. So what you can do is take the 150 milligrams, put in a 50 bag or 100 bag. Use a 10 drip set. Why? Give it over 10 minutes. The 10s cancel out. So what's your drip rate? Whatever bag you use. If I put 150 milligrams of amiodarone in a 50 bag, then it's 50 drops per minute. If I put it in a 100 bag, then it's 100 drops per minute if I use a 10 drip set. Okay? So easy way to take the math out. All right? One thing we don't want to exceed is 2.2 grams in a 24-hour period. All right, let's get to mag sulfate. Actually, mag sulfate, we talked about this in respiratory. We talked about how this is a respiratory drug. Well, this is also a cardiac drug. This also falls under an antidysrhythmic drug as well. Well, what do we know about magnesium sulfate? Well, magnesium sulfate is a mineral. It's a mineral, and it actually acts as a a physical calcium channel blocker, right? So it could block the calcium. So it's essential elements that we have. This is a physical calcium channel blocker. All right, so it can block neuromuscular transmitters as well. So keep that in mind. So you could lose reflexes if you give too much too fast. But we give it to patients who maybe who are hypomagnesic. So their magnesium levels are super low. We can give magnesium, all right? You need magnesium in your system. What's the onset? It's immediate, an IV, 1 hour IM. Half-life, there's really no half-life on this, so we give it. And why we give this to a cardiac patient? We give it to a Torsades de Pointes, right? Which is also known as polymorphic V Tach. Because polymorphic V Tach is when you see the QRS complex all look different in V Tach. It's just that bizarre looking QRSs. Turn into the points, right? So that bow tie effect. What's happening there is the ventricles are so irritable all over that the cells all over the ventricles are firing. The irritability is unbelievable. There's no stability of those cells in the myocardium, the ventricles. Mag sulfate actually stabilizes cell membrane. So if we stabilize all those cells in the myocardium, now it can fire down its normal electrical pathway. And now we eliminate that Torsades, we eliminate that polymorphic V Tach and get them back into that regular rhythm. So it stabilizes cell membrane. That's why we give it in Torsades. This is probably the first line drug if you recognize Torsades, because we know it's creating Torsades. The instability of these cells, them being so irritable. Give the mag sulfate. All right, be careful, could cause the patient to become shocky, smooth muscle relaxer. Could cause persistent hypertension, severe hypertension, third-degree heart blocks. We don't want to give it. Patient is hypokalemic. What do we tell you it is? It's a calcium channel blocker as well. So if they hypokalemic, they don't have enough calcium, don't give mag. It's going to make matters worse. Should be administered slow, super slow. Let me tell you, the faster you give it, the worse outcomes. But in Torsades and cardiac arrest, we'll give over 2 minutes. If the patient is alive, we'll give it over 10 minutes, okay? The longer you give it, the less side effects you see. And these are the side effects, some of the side effects you see: flushed skin, sweaty, bradycardia, loss of your deep tendon reflexes, drowsiness, coma. I mean, there's some more than I even listed here. Death can be an issue when you give too much mag too fast. All right, cause arrhythmias, hypotension, hypothermic, itchy, respiratory depression. It could suppress your respiratory system if you give it too fast, too much. All right, can cause cardiac conduction abnormalities if administered in conjunction with any digitalysis, such as, the Lidocaine or Lidocaine, those types of medications. All right, so we give it Torsades. What's the dose? 1 to 2 milligrams diluted in 5 to 100 milligrams over 10 to 15 minutes. This is if a patient has a pulse, Torsades with a pulse. If it's Torsades without a pulse, then we give the 1 or 2 milligrams over 2 minutes. Okay? So this is part 2, series 2 of cardiac medications. Once again, go back into your books, hit it up. Study those antidysrhythmics. Very, very important to know them. You're going to know them in cardiac arrest. That's what we give them. What patient gets what antidysrhythmic, all right? What patient gets calcium channel blockers. Those are very important. So I hope you guys enjoyed the 2-second series of the 4-part series. Stay tuned for series 3 of 4. Talk to you soon.